Yes, sir.
Okay. Thank you for this opportunity. And I thought even more important than retinoblastoma is what's going on in India. So, from those of us from outside of India, we're sending you a big heart. A year ago in New York City, we were a true disaster with bodies. They didn't have places to put the bodies, and it couldn't have been worse. And our hearts truly go out to all of you. And we got through it, and so has everyone else, but it was many months of awful. So yes, I'm going to talk about what I like to call chemosurgery for retinoblastoma. I'm going to talk about off-label use of drugs. As you know, there are no chemotherapy drugs approved in the United States for children. A comment about our retinoblastoma program. It's the world's oldest. We've been going for 107 years. It's been run by 3 physicians, Dr. Reese in the center, Dr. Ellsworth on the left, and a much younger Dr. Abramson on the right. We started at Memorial Sloan Kettering many, many years ago, have been around to many institutions in New York City, and in 2004 came back to Memorial Sloan Kettering. And since we've been there, we've done more than 20,000 examinations under anesthesia for retinoblastoma. The program is pretty well known. Probably the 3 things that it's best known for are the Reese-Ellsworth classification, the work we've done on second cancers in retinoblastoma. Remember when we started, everyone thought they were late metastasis, and the intraarterial chemotherapy. And really, I could summarize this talk very well with the next 4 slides. In 2003, just before I moved to Memorial, published a paper on our experience at that point, and we were saving 86% of the lives and saving 4% of the eyes. So despite the excitement and success of radiation, in reality, considering all unilaterals were being enucleated and most of the bilaterals had some enucleation, we weren't saving very many eyes. And lo and behold, in 2019, when I wrote a somewhat similar article, we could point to patient survival of over 99% and ocular survival of 95%. And I don't think you're going to go very often in life from a 4% survival to a 95%. And everything we do from now on will be working up, I hope, from 95%. Miraculously, 90% of these children have 20/20 vision. Now, of course, the unilateral patients who have enucleation have 20/20 vision, so that doesn't really speak to our skills. But if you're a family member, it's quite encouraging. How did we do this? We did this simply by saving very advanced eyes. These are eyes with advanced disease. All of them I've followed for more than 10 years after intraarterial chemotherapy, and all of those eyes were saved. The story of intraarterial, I think, is well known by everybody. It was really first done by Algernon Reese. He injected chemotherapy into the carotid artery directly in the hope that it would go to the eye. We now know that almost nothing got to the eye, and he was simply delivering what we would call intravenous or systemic chemotherapy through the carotid artery. Far less than 1% of the carotid artery gets into the ophthalmic artery. And it was really Kaneko in Japan, here shown with me on a memorable boat ride. Carol and a few others were there, who developed the microcatheter looking like a Foley catheter and introduced the use of melphalan. And they had very good results, but it was not widely accepted or understood. And part of the confusion was that the eyes that had intraarterial also had external beam radiation and hyperthermia. So the eyes did well, which is good news, but it was hard to know the contribution of any of those. Some people thought it was actually all about the hyperthermia. It was hard to know. In 2006, Pierre and I introduced the modern technique being used with the 3 drugs you know. And I think you're all familiar with this. This is a cannulation, usually of the femoral artery, but by no means do you have to do that. We, Carol, and I think others have used other sites, as is done. The catheter is passed up through the abdominal aorta, through the thoracic aorta, into the internal carotid artery, and then just to the orifice of the ophthalmic artery, we can get a very nice angiogram. And here it is. And in May of 2006, with an IRB approval, we had patients scheduled for enucleation to whom we offered intraarterial chemotherapy. And here's the first case, very advanced disease, obviously. We did the treatment, we had chosen the doses, we hadn't done any animal experiments, and I'll get back to that a little bit later. And 3 weeks later, the patient came in. And we knew that the world changed in May of 2006. Interestingly, that child who's here next to me with her permission, at the age of 14, is pretty tall. As you know, I'm pretty tall, and I think she's going to be taller than me. This actually stimulated us to look at the growth patterns. With systemic chemotherapy, as you know, growth is affected, usually, but not always. The children catch up. With intraarterial chemotherapy, the growth is not affected, telling you that they really get trivial doses intravenous. Well, the technique's been adopted worldwide. I'm not going to bore you with all the details, and whenever I show this slide, I am out of date, but it has been done in more than 50 countries. But more importantly, everyone has been able to replicate the results we had. In the United States, it's done in all centers except St. Jude. This is just one of many really good papers by Carol on their experience with intraarterial chemotherapy, in which they conclude that it's safe and effective. Argentina was one of the earliest adapters of this technique. In 2018, they said it was safe with a low complication rate. And later on, their title said the whole story. It's more effective than sequential periocular and intravenous chemotherapy as salvage treatment. Switzerland has been a leader in recent years. I'm sorry, Francis Meunier is not on this. They have published a number of papers. And again, their title says what they thought. First line, intraarterial versus intravenous chemotherapy in unilateral sporadic group D retinoblastoma, evidence of better visual outcomes, ocular survival, and shorter time to success with intraarterial chemotherapy. Italy was the second or third country to adapt this. They also said it was safe and effective. There have been many excellent papers from India, including a number of them in collaboration with Carol. And the conclusion there was the accumulated evidence shows that it's more effective in providing eye salvage in group D and E compared to conventional systemic chemotherapy. From China, many articles. I've been to China many times, and they are doing the exact same thing. They conclude that it is safe and effective with high success rate. From Chile, the conclusion was it was safe and effective, and they were able to reduce enucleation rates. From Turkey, intraarterial and intravitreous were safe and effective. From Thailand, safe and effective. From Spain, an attractive alternative for the management of retinoblastoma. From Korea, safe and effective. From Mexico, safe and effective. From Sweden, safe and effective. From Pakistan, effective. From Malaysia, the same story. And there are a number of literature reviews, interestingly written by people who don't do it. This literature review in 2016 concluded that it provided minimally invasive, safe, and effective alternative approach. And just this past month, a review of 316 published articles concluded intraarterial chemotherapy is associated with high rates of globe salvage, low rates of serious complications. So the proof that something works is that someone else can do it. So when do we use it? Well, this is the question I get asked all of the time. 95% of all the eyes I see get intraarterial chemotherapy as first treatment, whether it's unilateral or bilateral. And as I mentioned earlier, I can assure you that my colleagues in referral base don't like to send me simple cases. We enucleate 5% of the eyes at presentation. This is true whether it's unilateral or bilateral. We use it as primary treatment for unilateral retinoblastoma, of course, primarily in group D and E. That does not mean we treat every single patient with E, as I alluded to earlier. And you save 95% of those eyes. And for primary treatment of bilateral retinoblastoma, you save 95% of the eyes. We always treat both eyes on the same sitting, one eye carboplatin-based, one eye melphalan-based. What about salvage treatment, which represents half the patients I see? They've already had intravenous chemotherapy and progressed. We save the same percent, but we require much more treatment because little bits and pieces are growing and give us problems. And really something for which I've gotten a lot of credit, but I don't deserve, is the observation that patients who recur, massive recurrence after intraarterial, or talking about retinal recurrences, if you treat them with 3 cycles of the exact same drugs, the exact same route, the exact same doses, which makes no sense, of course, you save almost all the eyes. And we publish it, you save 83% of the eyes. Carol published very similar results. So the idea of going back to the same treatment that appeared to fail actually works. If there are no vitreous seeds, you can save almost all of those eyes. So let's just show you some eyes. All of these eyes were treated. Take a look at the retina. All of these eyes have driving vision in the United States. Thanks to my good friend Guillermo Chantada treating orbital invasion, we have progressed to use intraarterial chemotherapy for the orbit. Nothing but intraarterial chemotherapy here. As you know, we had demonstrated that topotecan given intraarterially gets into the optic nerve in very high concentrations. So we've moved to treat patients with optic nerve invasion successfully. What about eyes with retinal detachment? As was pointed out in the original classification in Group E, it was said that if you have a hopeless eye with no vision, it should be removed, which I think is totally appropriate. I did that for 30 years. But I come across families who will not take the eye out. So we began treating them, and lo and behold, 25% of the eyes with extinguished ERGs, afferent pupillary defect, no vision at all, regain some level of ERG function. We and Carol have pointed out that for deletion syndrome patients who are very difficult to treat with systemic chemotherapy, that it is a much better choice with intraarterial because there's far less toxicity, but those patients do have more toxicity than your average retinoblastoma patient. But what about patient survival? Because it's nice that we save so many of these eyes, but are we compromising life by treating these advanced eyes? In 2015, we collected 634 patients from New York, Philadelphia, Lausanne, and Buenos Aires. And of that, more than 99% survived and did not have retinoblastoma. And then in a larger paper, including New York, Philadelphia, Brazil, Switzerland, Italy, and Argentina, on 4,396 infusions in 1,139 patients, there were fewer than 1% metastatic retinoblastoma deaths. And remember that at least in the United States at the present time, patients who have primary enucleation of unilateral retinoblastoma develop metastasis about 4% of the time and die just under 2% of the time. What about second cancers? Well, we've eliminated the second cancers from radiation, as we did eliminate when we were doing systemic chemotherapy. We believe we've eliminated the second cancers from systemic chemotherapy. That's not only based on our data, but based on the more than 30-year experience using the same drug in Japan. And we've had no impact on pineals. you still develop pineals exactly the way you would develop them in those patients with the germinal form. And finally, just a really fascinating thing. I began this with an IRB approved study in humans. We did not do animals. We did not do laboratory tests. Since our publication and since everyone's experience, we and others have done primates, have done pigs, have done rabbits, and all of the studies are kind of similar, and they tell you that the dose that you're going to get in those animals is not going to be high enough. So if I had started with animals and we would have been discouraged by the results, I never would have done humans and wouldn't have had the opportunity to give this talk. Thank you.